are very familiar with the use of a semen spacer, and then after induction, after production of the membrane, then now you can put cortical cancellous graft or cancellous graft as the case may be. The reactive membrane that forms protects the graft from resorption, and it also secretes growth factors that promote healing of the bone graft. However, this surgery requires 2 stages, and it is presumably more difficult in lower limbs where a longer period of consolidation of the bone and remodeling is required. And therefore, where there are higher stress loads, particularly if it's a very long segment, it may not be advisable. Therefore, this technique is indicated in patients who have smaller defects and also in upper limb lesions. The second technique is the use of segmental bone transport. And segmental bone transport involves removal of the tumor, and the resulting defect is by transporting a fragment of the bone, a section of the bone, down to the area of tumor resection, and this intervening area is replaced by new bone formation. It is biological, it is permanent. However, this is a long and tedious process. It is associated with problems with pin tract infection, requires multiple surgeries. Patients also have problems with the docking of the docking site, and you may have malalignment. Therefore, this technique is very good for children because they will heal quickly. It's good for average size defects, and it's also good for patients with a long life expectancy, because if the patient has a short life expectancy, then the process will outlive the patient. The third option is the use of a free vascularized rib graft, fibular graft. And now, the fibular graft requires microvascular anastomosis, and in the tibia, it can be hooked to the peroneal vessels or to the posterior tibial artery. It's hooked to the posterior tibial artery because of the supply because of the pedicles to go into the fibula. Now, the option is a good one because this is a viable graft. It has blood supply, it does not require clipping substitution, and therefore it responds well to loading and the bone can hypertrophy. However, you need this microvascular capability. The problem with the fibula is that it is small, and therefore it is not an optimal fit for the place where you want to, not unless you're doing it in children or you're doing it in the upper limb where it may be of a sufficient size. And therefore it is prone to fatigue fractures in the long term. And therefore, because of these disadvantages, it is indicated in lighter stress areas, particularly in the upper limb. It's because of its location of the donor site, which is the fibula. The midshaft area is a preferred graft area or transplant area, and it's good for use in pediatric patients. Because of the problems that are inherent with the fibular graft, in situations in which one has very large intercalary defects, it means that that fibula has to be protected for a long time, and this can go up to 2 years as you wait for it to hypertrophy. And therefore there are options. One option is to do a double barrel fibula, where after breaking the fibula and preserving part of the periosteum and tissues, then you can make it into a fold it over, so that then it's a double barrel, and that can fit better where the defect is large, for example, if you are transplanting to the femur. But the other option is to combine it with an allograft. And allograft is not an autograft. Therefore, the moment you use an allograft, then you introduce the disadvantages of allograft, which include having a bone bank, which means that you have also a risk of infectious disease transmission. But the advantage of combining with an allograft is that you are able to take in the advantages of using of the biologic activity of the free vascular fibular graft, and also the advantage of provided by the allograft, that is mechanical strength. And therefore, with those two, then you can be able to expand your options for the patient. However, it's a lengthy procedure, and therefore, in spite of this, most people would be hesitant because by the time the graft is harvested, that has taken time to isolate the vessels and hook them up, and now you are adding an allograft into it. Now, this allograft can be done in two ways. One way is to open up the edge of the allograft so that then you can slide it in so that it is intramedullary, or you can do an onlay technique where the fibula and the allograft are laid side to side. Now, number 5 is the extracorporeal devitalized tumor-bearing autograft. And what basically this means is that you're using the tumor, that bone that you have excised, and putting it back. So it's basically a recycled autograft. And therefore, what this requires is removal of the tumor, as shown in this case, and the following tumor resection principles, and then clean the specimen of the extra tumor by either shaving it off, using curettes, or if it's a long bone, by reaming the long bone. And therefore, then you can, and thus include one is pasteurization. And pasteurization is heating the bone, or the tumor-bearing bone, up to about 60 or 70 degrees and over a period of 20 to 30 minutes. Now, pasteurization is good because it preserves factors, including bone morphogenetic protein. That's why there is a set limit of 70 degrees. After 70 degrees, BMP is destroyed, and therefore it seems to preserve that, and it also preserves osteocytes. Therefore, pasteurization is shown to be a good technique in the short term. The other option is autoclaving, and autoclaving is done at a higher temperature, about 120 degrees centigrade or 135 degrees centigrade. And then the other option is use of extracorporeal radiotherapy, where after removing the bone, then the bone is sent to the radiotherapy department and irradiated and then brought back. So that's the disadvantage of radiotherapy, but again, it works well. The other method is freezing the bone by using liquid nitrogen, and I wanted to show this video, please, what we did with our patient. So, So liquid nitrogen, you can stop. Liquid nitrogen, as shown here, is readily available in studies that have been done. So the difference comes in terms of union. If you use an extracorporeal pasteurized autograft, it seems to have the best union because it preserves the biology of the graft. However, it seems in large studies that it is not durable, and therefore it's proving to be a bit disappointing. Extracorporeal